Hello, my name is Heidi Kozakowski, and I'm a physical therapist and senior practice specialist at APTA. During this live event, we will discuss the Building Trust Initiative by the American Board of Internal Medicine, or ABIM. And we'll discuss with the PTs who were selected to represent APTA in the initiative. So sharing their trust practices today is Dee Daly, Fred Murphy, and Michelle Beltram. So first, I'd like to share some information on the Building Trust Initiative and APTA selection process for trust practices. In early 2020, ABIM invited healthcare sectors to collaborate in their initiative to elevate the importance of trust as an essential organizing principle to guide operations and improvements in healthcare. This was done because polls revealed that America's trust in the healthcare systems is eroding, and trust in healthcare institutions can no longer be assumed. Some of the known consequences of mistrust in healthcare are decreased adherence to care plans, poor coordination of care, disparities in healthcare, professional dissatisfaction, missed opportunities for needed collaboration, and damage to organizational reputations. So initially, ABIM planned to launch their Building Trust initiative and web platform in the summer of 2020 and focus on 7 categories that are reflected, that many of the core attributes that the research has kind of shown define trust. And these are communication and knowing your patients, conversations and support, leadership, combating misinformation, patient-centered design, transparency, and value and affordability. So that was the initial plan. Then the pandemic hit and systemic inequities that affect healthcare were brought to light. So ABIM updated their call for submissions to include trust practices that responded to the pandemic and recognized that social and economic factors shape individuals' ability to engage in healthy behaviors. And we can see that building trust in healthcare is extremely important today, as we have witnessed the politicizing of health information. And we can see, for example, that building trust in healthcare can offer a tool to decrease things like vaccine hesitancy. So APTA made a call for trust practices in the fall of 2020, and then selected 3 to represent APTA in the Building Trust Initiative. ABIM will launch their Building Trust Initiative next week on May 21st, or I guess in 2 weeks on the 21st, in a webinar, and we encourage all those who are interested in trust in healthcare to attend. And we'll put the link to that webinar in the chat. So now I'd like Dee, Fred, and Michelle to take a couple minutes to describe their trust practices, and then we'll ask them a few questions. So if you're watching this live and have a question, please write it in the chat. So let's start with you, Dee. If you could just tell us who you are, and if people don't know, and then give us a description of your trust practice.
Exciting. My name is Dee Daly. I'm the Director of Clinical Practice at Workwell, a company that provides musculoskeletal health programs as part of employer health, safety, and wellness programs. So our overview of our trust practice is that we called it Worksite Embedded Injury Prevention Advocacy. And one of the reasons we did that was we wanted to make sure that we highlighted that this practice was actually occurring in the workplace on the front lines. So we were moving beyond the traditional, some of the more traditional clinic sites, and the clinic site actually sometimes even goes directly to the front line. So we create a partnership with employers and employees to deliver musculoskeletal health and injury prevention programs to keep workers safe, productive, healthy, and at work. That's really part of the goal. So the programs involve actually working in the workplace with the workers, supervisors, and safety personnel, doing ergonomics, rounding, injury prevention program activities. And we like to think of it as a blend of health advocacy, evidence-based practice, integrated health and safety, and relationship building. It's kind of this, this dynamic of kind of a vision that we wanted to bring to light in the clinic, in the clinical practice. So with that, I'm going to head it over to Fred.
Yes, hi. My name is Fred Murphy. I'm a physical therapist on the acute care department of Johns Hopkins Bayview. My trust practice was originally developed when I was in an outpatient department at Johns Hopkins Bayview, and it was to start to look at seeing about if we could develop a primary care physical therapy within the geriatric medicine clinic. I come about that because of the number of older adults that we were seeing in the clinic that, some of them weren't, really responding to therapy. And it was, I think important for us to start thinking about, being more proactive. Having a therapist, in a clinic, seeing within the geriatric clinic, we could start to address some of the fall risks, the other age-related neuromuscular issues that develop as that we get older. And given that we're in Baltimore City, there is also, prior to the pandemic, there was already an issue around, overall physical activity and challenges of the older adults to get out and begin to move around. Then when the pandemic hit, of course, that made things even worse. There's so many physical challenges with the residents of Baltimore City due to the socioeconomic disparities, and we've seen, in addition, since the pandemic, that many of those disparities have become, have led the older adults to having, more serious medical problems. Now we see a lot more holding off on their medical visits and that since the pandemic. And within this proposal, we had added the topic of trauma-informed care or psychological informed care, based on past patients, discussing, you might say, the violence and that have occurred in the neighborhood, and how that, those factors may have now, impacted the chronic medical conditions they have, as well as, that, impairing that physical activity and being afraid to get out of their home. Michelle?
Thank you, Fred. Appreciate it. Hi, everybody. My name is Michelle Beltram. I'm a physical therapist and orthopedic clinical specialist working in New Jersey as the Director of Education and Residency at Kessler Rehabilitation Center. Our Kessler Rehabilitation Centers are hospital-based outpatient rehab, multidisciplinary. Not all of our centers are multidisciplinary, but we do have over 100 centers as part of our organization and tied to Kessler Institute for rehabilitation inpatient hospitals as well. We have 3 centers there. And so our trust practice is our telerehabilitation program, which we started to investigate prior to the pandemic as a means to access care and other disciplines that maybe were a little further outside of the patient's ability to receive that care. So what we had done as in response to the pandemic is we had trained at least one clinician per center to be able to deliver either physical therapy, occupational therapy, and or speech therapy to allow patients that either were post-operative, had cancer rehabilitation needs, whether they were orthopedic or neurological, had issues that required physical therapy that in New Jersey weren't able to get out of their home based on quarantine, or were fearful to be able to get out of their homes. And so we converted those pretty rapidly, and now we have over 175 clinicians that are competent to treat our patients via a HIPAA compliant software to try to keep those patients safe at home. Many of our patients now are doing a hybrid type based care so that they're being able to be treated at home and in our centers when needed. And what we really were looking for is increased access to care, as I mentioned. So some of our pelvic health patients, we don't have as many pelvic health therapists, but we wanted to allow our patients to have access to those staff members to really help some of their issues that they were seeing. What we found is that it really allowed us to see patients in their home. It allowed us to continue their rehabilitation in a safe environment, in the environment that they feel like they are going to have to operate in. So we were able to do some kind of almost home assessments, I guess, so to speak. And we've been able to offer it to parents treating pediatric and infants, all the way to geriatric patients, well over 100 with their family, being able to help support them if they require any type of intervention. What we found is that we had increased access to our occupational therapists as well as our speech therapists. So this trust practice, we feel like, have been very positively received in our communities, and we're excited to be able to maintain this level of care and access to care for all of our patients in the state of New Jersey.
Great. Thank you, everyone, for your descriptions and submissions. And we're really happy to highlight them at APTA and hope that going forward that we can, this is just really opening up a conversation about trust in physical therapist practice. So now I've got some questions for you. I'll direct them to each person, but feel free to chime in. The first question is for you, Dee. In your trust practice, what was the problem you were seeing that you were trying to address?
Thanks. We were really trying to focus on how to prevent work-limiting problems. Because we partner with employers, part of our goal is to how do we reduce costs, reduce injury, and increase health. So it's kind of a complex problem. That also involves helping people stay at work who want to stay at work, who have chronic conditions. We often work with people who work long shifts. They might be in areas that don't have health services. And there's also some perceptions that maybe the medical system doesn't care about them, or that they feel a sense of marginalization, and that can really negatively impact health, and or we've seen it lead to deferred care. So by trying to address some of the root causes of the problem, we felt that we would be able to increase health and increase access and reduce some of the barriers to care, so that we made it a little bit more seamless and we were getting at things before they became problems or things that could impact people's economic livelihood. We were surprised during the pandemic that we were, in many cases, automatically considered essential personnel, that the companies didn't even bat an eyelash. So that was really kind of an interesting development. And there were some changes, but in many cases, even some of the soft skills and some of the anxieties that may lead to pain and discomfort, we were able to at least provide a certain level of stability in all of that craziness.
Great. Okay, well then we'll move to the next question. And if Fred, you could start us off with this one. Thinking about if you wanted to implement a trust practice or you were thinking about creating one at your work, there's certain things that you might need to consider. So did you receive any resistance, or were there any barriers to implementing your trust practice, either by your administration, your colleagues, your patients, or anything else? And if there were, how did you overcome them?
Well, with my trust practice, since it was, we were just beginning to sort of talk about, the idea, after having, been working just prior to the pandemic in outpatients, and just seeing how these, older adults in the Baltimore City area and just outside of the city and the county were struggling. And thought, what if, if we could, start to see these people, and evaluate them and such, and do screenings, to pick up on, a variety of, issues that physical therapy could have an impact on before they actually become a bigger problem. And at that early stage, there were other, especially the geriatric medical clinic, had their own priorities that they, were working on. And then, of course, the pandemic hit. So the biggest obstacle for my trust practice has been the pandemic. Everything, just pretty much shut down in the beginning and is gradually opened up. There was, verbal support. I mean, and encouragement by many, I'll say many people. It's just, we haven't quite gotten back, sort of, I'll say to the, into, the conversation, because I think, the various medical clinics, especially the geriatric, have, I think, still, trying to, I'll say, ramp up, getting, to into seeing people in person, where they were just doing more telemedicine. And then myself, I was, redeployed from the outpatient department into the acute care side. So those were the bigger obstacles. And I think, now that things are sort of, changing around, I think now we can sort of start to revisit maybe some of this and see if we can move, if there's any possibilities of moving forward.
Did anybody else want to chime in on that, Michelle?
Yeah, I would love to share. We had three main barriers that slight resistance when we first transitioned to our telehealth platform. The greatest one is our clinicians. We are in a very manually focused profession, and the mindset of not being able to treat our patients in a way that was as effective, and myself being a manual therapist, I was just as anxious about being able to provide care for many of our neuro patients or patients that required balance training, to not be able to feel like we could be there to support them and to ensure that their safety. So that was one of the greatest barriers that we initially had gone through. And we did a lot of training with our teams to be able to implement different online platforms to provide across our entire corporation, to be able to really provide insight into safe ways that we can provide different testing, how we can teach self-mobilizations, different family handling techniques, and gait training, and different testing that we wanted to do. So gradually, as our outcomes became increased, and our patients were very grateful to have the care, particularly those that were either post-op or many of them were in an intense amount of pain. And then with the increased level of stress from the pandemic, that also increased some of those psychosocial levels of pain that they were having. And also some of our cancer rehab and our youngest infants that we were treating. So the clinician barriers were the initial biggest impact of that. Insurance barriers. So Medicare initially was not covering our telehealth. And so we were able to have some advocacy from our organization to be able to really allow the politicians to realize that this was something that needed to change. The insurance platforms then were starting to move forward. I think probably the easiest, which was most surprising to me, I guess, was some of our work comp carriers that really felt like they needed to get their people back to work, particularly if they were in an industry where they were an essential worker. And then lastly was really the tech barriers that some of our patients were encountering and our clinicians were encountering. It wasn't something that was innate for a lot of people, and not everybody has a laptop. So being able to use different smartphones and different things, where luckily many people have that now, or their family or friends have that, and they could utilize those platforms. But having our clinicians learn to maneuver through instructing some of those tech barriers was another barrier that we had overcome, and really excited to be able to move forward on all that. But those were our biggest barriers from the pandemic.
Thank you. So this next question is actually for all of you, but Michelle, I'll have you kick this one off. Was the objective of your program to specifically build trust, or did an increase in trust kind of result out of the program? So, as we kind of, as a profession, start to look more into trust practices, it could be very explicit, or we could identify places where we're already doing it and want to expand on it. So if you could start the answer for that one, and then the others, Dee and Fred, if you want to chime in as well.
Thank you. Yeah, so I think it's a combination of both. So I work for Select Medical. We're a branch of Select Medical. And one of our cultural behaviors is building trust. So I think that that's a staple in everything that we do. So any type of new program that we're designing always has that as a tenet of what it is that we're doing. So we did want to keep that in mind as we move forward. I think from our patients, what they were telling us that we saw that increasing the trust and therapeutic alliance and rapport with them really allowed them to feel more comfortable with telehealth. We can take their comments and really modify our platform for our entire organization to allow us to really see that it mattered to them, that they were inviting patients, they were inviting us into their homes for care, that we, in sometimes into very intimate areas of their homes where they're not used to having strangers into. So we did take that as a really high level of trust and responsibility. And I think that, although it started out as one of our tenets that we were building trust, we really recognized the importance of it. And, we started with a HIPAA compliant software and we maintain with that. But I think our trust practices had definitely grown as our practice has grown.
Okay. So I think it's same with my proposal. I think it's definitely would be, be some of both. I saw when I was an outpatient, before I wrote up this submission, that, the time we spent with the patients, we were building that trust, and we go from that trust to building into what we call relationship-centered care, especially with these older adults that come from, especially Baltimore City. There is that lack of trust of the health systems throughout the city. And Johns Hopkins is a big proponent for building that trust, and as as being the PT in an outpatient, that's what came to me, is if we could just sort of think about the idea of primary care PT, just like the primary care physician. If we we're able to, like I said, see these people early on and develop that relationship-centered care and understand the sort of the underlying sort of experiences that they a lot of the people in Baltimore City experience from day to day, and how that can impact many all of every part of their health, and applying that knowledge towards helping them to sort of improve their quality of health, let's say. And so that's that I think it goes to the both pieces of building trust, and that's all I have to say about that.
And we saw the need for relationship building and advocacy as part of kind of our first generation practice. So as we kind of went into second generation practice, we were specifically looking at some of the barriers to care and trying to overcome them. So we had workers who may initially not be sure about how they were going to how secure and private their encounters were going to be. We had supervisors who were kind of worried about how we were going to maintain productivity and still deliver services. So for us, it was we made the bet that we had to bridge, and advocacy and relationship building were the bridge to get between workplace and health. And outcome was really our trust was really our outcome that we wanted to achieve. And we knew it would be critical to long-term success, but it was really the foundation of how do we build trust instead of saying trust was what we were going to do. It was what's that comprised of? And that's really the kind of the soft skills that we had to try to figure out to navigate, because it's the add-on, if you would. I think Michelle used the term therapeutic alliance, and it's that add-on that it makes such a big difference. And so that was really one of the things that we tried to focus on as an outcome. And so it was interesting as you asked this question about how do we, was it the chicken or was it the egg? I think we all started and ended with it the same thing in mind.
Yeah, and I really like how the intention behind it, and just thinking about like what Michelle and Fred were saying, they kind of leveraged their previous experience and their previous trust with their patients to implement a new activity like telehealth, or like that we know that there was a lot of patients and providers and everyone that were, like you said, scared of it. So you really were kind of cashing in some trust, and in the process building more. So, and I love that. And I love, Dee, that your project was really intentional, that trust was the outcome. So that begs another question for you, Dee, is how are you measuring that? For everyone.
Great question.
We got to measure everything, right?
Well, and in many cases, when we started, it was engagement. It was how many touches are we getting? And so if we want to build trust and relationships, then there has to be engagement, and not just kind of us saying, hey, we're going to offer this to an empty room. But we started off by how long did it take for people to kind of come to us? And there are the early adopters and there are the mid adopters. And then there are the people that really will break your heart sometimes, and they'll say, hey, work is the safest place for me. I don't need you taking me out of work. And it was like, wow, that was an aha moment. And I'm here on behalf of others that want to know if they can trust you to come to find a solution for us. And, those are really deep conversations. And I'll bring it back up a little bit and say that it also mattered to the workers how often we were in their workspaces, because then it was like, you really understand what I do. And so I think it was an equal measuring. They were measuring us, we were measuring them. And we do look at surveys, and we look at overall how many dollars are saved. So we look at metrics that are important to the end user, but we also then look at how many people are actually touching services that they would not have gotten. And people are pretty frank about that. We don't actually have that metric, but it's one of those things that we're working on. And so it's been fulfilling to actually see people say things like, I've been putting this off for a year or 3 years or what have you. So I hope that helps a little bit.
While we didn't quite measure trust, so to speak, we did continue to utilize our Net Promoter Scores to ensure, to see really what our patients were thinking about their experience with our telehealth. And I appreciate, Dee, that saying that trust is the outcome. I mean, that's really phenomenal to really have that forethought to be able to go there. But I think that our Net Promoter Scores was a measure of, I guess, the way that our patients were rating us for trust, and they didn't decrease at all. And in fact, during the pandemic, they actually increased because I think they were having some access to care and being kind of a little bit more socially isolated, that they felt really happy to see us. And it was funny, sometimes they would come in our center and then they couldn't be in, and we're wearing a mask, and they said, oh my God, I didn't even know what you looked like, and now I can actually see you. So that was kind of appreciative moment. And then our use of our patient reported outcomes as a measure of their improvements for their care we did spend a lot more focused time on utilizing those during our telehealth platform, and our patients were really demonstrating improvements of care. And, to date, we've done over 15,000 visits, which, is pretty impressive, although quite a bit less than we were during the pandemic. I think that this is a platform that's here to stay, and partially because of the trust that we were able to build during the pandemic.
So yeah, with the trust, again, I think the biggest, thing that I've seen, I don't have an idea of how to measure the trust in regards to my submission, or the trust practice, I should say. But I've seen it, just in the day-to-day, workings with some of these patients that we've seen. And, some people, say, well, I'm going to just come, I only want to see like Fred or somebody. And there's that trust. Moving on from that type of trust is, if we could, be seeing some people early on, then and have that sort of built-in trust, maybe, we're able to sort of, keep them out of the hospital, reduce hospitalizations, with the amount of education we could even provide people, and ways to sort of monitor their skin. So we reducing, amputations. I mean, there's so many, I think there's just so many areas that we, probably could impact upon, having that relationship and that, that trust, that I've seen over the years in, having worked here at Bayview with, patients from the city, and that just, come in with sort of this skepticism about, the health system. And, I think the onus is on us, whether you're an outpatient's acute care or whatever, to, actively listen to, your patients and understand not only what they're there to see you for, but, what other things do they deal with outside of, the clinic. How many times, people report of, loved ones being shot or friends being shot or this or that, and they coming in, after having, having these experiences. And I think that it, of course, affects, just how they present, and not to have, sort of acknowledge that, and, and use the terms of like, what happened to you, not what's wrong with you, what's happened to you, so that, we factor in, the current traumas that people go through and past traumas that have an influence of the delivery, and that strengthens that trust, bond there.
I think, Fred, that's such a good point. And I think as a profession, as we go more towards acknowledgement and understanding of social determinants of health and how they impact someone's recovery and their, how can you optimize functioning with these other factors. So for you and the therapists at your work, did you receive any training on how to ask those questions and how to kind of create that safe space for a patient to talk about that?
Well, no, it's just been on my, just myself, having read, numerous studies, read a book about called The Deepest Well, that talked about adverse childhood experiences, and that sort of led me to that, that trust piece, because we haven't seen, some people not get better and then wonder why, one does and one doesn't, and is there other underlying factors, and so it's been more of a self-learning, in having looked at the trauma-informed care principles. I've had conversations with other medical providers, and they all sort of have agreed, that there's it's important that we think of the trauma-informed care principles or psychological informed care principles. It's just nobody has come forth with, how do we do that? I think there's still this concern that if we ask the question, is that going to push somebody, into more psychological distress or something? And then who do we have? Do we have immediate access to a mental health professional? I read one study where they did a survey and asked those individuals that have had trauma or an adverse childhood experiences, if asking the question of what has happened, would that make them have a feel more, I guess, psychologically vulnerable, and most of them feel relieved when people ask a question. And so I think that's still a work in progress. There was a research article not long ago if I just quickly look here, Archives of Rehabilitation Research and Clinical Translation that did a nice job. It's titled Adverse Childhood Experiences in Trauma-Informed Care and Rehabilitation Clinical Practice. And they have a flow sheet, and they use some simple things such as, just sort of approaching the subject that, certain events in life can cause different things, or exacerbate different things. So, and open it up that way. And some patients will just, be, pretty straightforward and provide, and say that, say what's happened, and then you help them, understand, that, it's not, it's not them, it's the event that's caused, some of the problems that have led them into therapy, such as chronic medical conditions that develop, as research has said. So yeah, I mean, it's still the actual sort of, you might say, training and is still a work in progress. I mean, there are sort of some organizations out there that do some training. Some are geared to psychologists and so forth, but there's a fair amount of information that you can have access to out there. ACE's Connection is a great one on trauma-informed care and so forth, and they have webinars and blogs and things like that from other mental health professionals that do that.
Would you mind maybe putting the name of that in the chat in case there's others who want to find out more information? Fred, I applaud you. It sounds like you're beginning your journey on this, just like Michelle and Dee are. You guys have all kind of started these new projects within the last year, responding to a need. So my question for all of you, and maybe we'll start with Dee and then go to Fred and Michelle. What are your next steps? Or are there any, or is it complete and you're going to replicate in another location?
We have an ongoing set of facilities that are onboarding intermittently. COVID definitely impacted some of the newness of things as they were evolving, but we certainly want to do more with continuous improvement. Finding ways. We wound up after kind of first gen adding additional training. We developed internal training to help with consistency, to help with reproducibility. We really want the clinicians to begin to engage and have a learning community so that they can support each other and kind of cross-pollinate. We know that some of the facilities that we work with are connected, and so helping connect the therapists has been something we've been doing, but we want to get more diligent with it. We also want to improve some of the information that we're giving. We're working with dashboards and things like that so that again, the frontline worker sees a better experience, but the C-suite is also seeing better data. And so trying to scale and making sure that we consider all of our stakeholders is front of mind. But each of those projects, it's almost like you're running projects on three fronts. And so it makes it harder to be, quickly and rapidly deploying things, but we're working to do that better and better and just continue our understanding. We are consistently also challenged by the employers. So employers expect evolution and improvement on our part the same as they do in their own organization. So they consistently challenge us. So in amongst our own goals, we lop theirs in as well. So it's just an ongoing work in progress.
Great, thank you. Fred, do you want to tell us the next steps? You think you're on mute. We can't hear you, Fred. All right, well, let's move to Michelle. There you are. Okay.
Sorry, what was it?
The question was, what are the next steps? So we understand your state. Do you have plans for moving forward or updating anything in your plan? Or
yeah, I mean the next steps, for my trust practice, I think is just revisiting the conversation amongst our administrators in rehab, geriatric medicine. And maybe, there might be, we might look at, see if there's opportunity for funding, to sort of maybe even pilot, this practice at some point, maybe in the near future.
So I guess for my next steps for our tele-rehab program is really similar to D, is continuous improvement and refinement of what it is that we're doing now, rather than sort of requiring all staff to start to get trained. We developed a more comprehensive competency program consisting of some training, some written exams, and some practical examinations, and really support for our staff to allow, a little bit more regional support to really teach them how to develop that therapeutic alliance, how to continue to ask those questions, how to treat manually where you're not, in person with someone, to really expand and allow some increased levels of mentorship. So allow some of our staff to almost co-treat remotely and virtually with the patient and another therapist. So increasing that access to specialized care is what we're really looking to do. And then really to hone our skills to allow that focus and delivery of care from really a patient experience angle. So whatever, as kind of Dee mentioned, whatever the stakeholders are, if the employers require something for work, we can provide that in a work environment. If we need to do something for home sometimes, and maybe look at somebody's specific situation, we can actually go into their home and do a home assessment and treat them in that environment. So that's sort of our plan, is to continue to increase access to care that way, increased access to our specialized therapists, and really hope to deliver an improved model where it may be all virtual, it may be all in center, but that there is a hybrid base. So if working parents aren't able to get to therapy that day, we can easily convert them to telehealth so that they can continue on their progress for therapy. And even as a check-in a month or a few weeks after therapy, just to really check in to see how somebody's doing. If it's a vestibular based patient, just check in with them face to face to really, in a HIPAA compliant way, really respecting their privacy, but ensuring that we're managing our patients over the course of their entire lifetime.
Wonderful, thank you. And we're going to just wrap up. I appreciate everyone's time and work in this area. It's helping the whole profession and the patients that we serve. So if you could just kind of go around, we'll start with you, Michelle, then go to Fred, and then finish with Dee. If you want to, if you have any last kind of parting words or advice for other physical therapist assistants who are thinking about developing a trust practice where they work and with their patients that they see.
So, I think really focusing on the needs of the community and the needs of our patients is something that we need to all continue to focus on and develop our practices based with the patient in mind, very patient-centric. As far as telehealth goes, the APTA is doing a wonderful job with their telehealth certification course on the Learning Center. So really teaching students and newer clinicians and more experienced clinicians to really give them an access to learn some information regarding the safest and best practice for telehealth, which I think is a great entry. And I think it is going to be a more entry level skill where we didn't really find that at first. So I'm really excited to have taken part as a part of an elective course, but I think the APTA has really done a phenomenal job to really get the information out for everyone. So I would encourage specifically for telerehab or telehealth to look at that platform and continue to be patient-centric, really focused on the needs of our patients and the advocacy to maintain telehealth and a lot of what we do beyond the year 2020 and 2021 to allow insurance providers and Medicare to really understand the needs and to get the information out to the community so our patients really know that we are essential and that we can treat them in whatever environment that they need.
Okay. So what I would say is, especially, with the patient population that we see and, given that we're in Baltimore City, I think it's imperative that, again, that we look at these principles of trauma-informed care or psychologically informed care and look at, the socioeconomic disparities and how those things affect our patients as they come to see us. They're not just, someone coming in with a rotator cuff or low back pain. And when it comes to, of course, chronic pain, I think there's a lot that we need to, consider, in treating these people, because I think, some of these experiences that they have lived and continue to live do impact our delivery. And to say that they're not gonna, they've either failed or been non-compliant, we need to have that, try to do as best we can with building that trust, to see if we can succeed with those individuals that are more challenging. And when patients do build that trust with you, things do change in a positive way. And we may even influence, you might say, their compliance with, with what, the other medical providers are, have been, working with them. And then, from there, like I said, we might even, impact, their chances of hospitalization or other things, or other, major problems that will impact them for the rest of their lives.
And I'll build a little bit on what Fred said. I'll start with kind of the regular typical skills, right? So one of the places I'd recommend that people may want to start looking is in Total Worker Health Resources. It's a CDC initiative that's really gained a lot of traction. There's some really good research coming out on the topic, and it's really integrating safety and health. So again, it's clinical care within the context that of the people that we're trying to work with. And I think that's so powerful, and understanding. APTA has resources for direct to employer services, and the occupational health special interest group of the orthopedic section has a whole special interest group on that involves working with employees and employers. But beyond that, I guess getting at those those people skills and understanding really diplomacy and therapeutic alliance and the non-clinical competencies of organizational behavior. How do we influence things? Understanding workplace safety and what does that really mean, and where there are both regulatory and practical things that we butt up against that don't have to be resistance, but a lot of times clinicians and workplace stakeholders don't know any other way. And so finding a third way can be a really interesting experience. And it's so fulfilling when you think about the folks that are vulnerable and they can benefit from not just the traditional clinical care, but addressing those other aspects of social determinants of health that we can kind of sneak in. And being in the workplace, we can sneak them in a little bit at a time, and all of that kind of fun stuff. And tying it all back to COVID, since we did say we were going to talk a little bit about COVID today, I just want you to know that I work with the people who make the toilet paper, and they are working hard to make sure you never run out of toilet paper. So, I think meeting people where they are means that we're helping society, even if it is on a very basic and essential level.
Thank you for that, Dee. I'm glad, me 2020 is just so happy to hear that there are people out there still working and doing that. So thank you, Dee, Fred, Michelle, for all of your time. If you're listening to this later on after Friday, May 7th at 2 p.m. Eastern Time, if you're listening to the recorded version and you have a question, you can email practice@apta.org. And I can get a question to Fred, Michelle, or Dee, and we thank you for your time. Take care.